good afternoon, everyone. Welcome to the latest installment of EMS Focus, a collaborative federal webinar series. My name is Noah Smith. I'm a project manager here at the Office of EMS at the National Highway Traffic Safety Administration. And together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for emergency medical services. The projects we undertake and the resulting resources for the community help to plan for system improvements, measure the health of EMS systems nationwide, and we deliver the data that EMS leaders need to advance their individual agencies and systems. Another role of our office is to educate the EMS community on new innovations, processes, and technologies that can, in the end, help provide better and more efficient patient care. This free webinar series, which is hosted by NHTSA, is a unique opportunity for federal EMS agencies to share information with the community in a manner that's more personal and less time-consuming than attending conferences, but offers the community the opportunity to interact and to ask questions that a newsletter or an article just doesn't allow for. EMS Focus conducts webinars every other month on issues that are important to the EMS community and provides you with timely information on what us at the federal level are doing to improve care across the country. Today's webinar is being recorded and will be archived on www.ems.gov for future viewing and listening. And more information and all of our past EMS Focus webinars can also be found on ems.gov. Today, the NHTSA Office of EMS is pleased to have several of our partners with us to discuss how we can use data to improve EMS systems of care. Improving EMS systems and the quality of patient care that we deliver is our top priority at NHTSA, and of course, a passion of mine and my colleagues. I might be speaking to you as a representative of a federal agency, but I have been an EMT for 10 years and continue to volunteer for a local fire department just outside of Washington, D.C. We're going to talk today about why data collection and analysis and utilization is so important. And although we don't always realize it, when we as EMTs or paramedics complete patient care reports, those PCRs are important for a lot of reasons. Not only do they help us communicate to the hospital information about the patient we're bringing in, what we found in our assessment, what treatments we administered, but the data in those PCRs also helps us look at the care we provide to our entire community, whether that be at a local level, a state level, or for the entire country, and helps us see if there are areas where we can improve or change how we deliver EMS. Now, I wasn't always passionate about data. In fact, when I began at NHTSA's Office of EMS over 5 years ago, I'll admit that I was a bit naive and came in with a laundry list of accomplishments that I wanted to get done. Well, it didn't take me very long to understand that improvements in our systems of care, whether that means a new protocol, whether that means a new intervention, a new reimbursement system, or a new delivery model, have to be data-driven. And I really became a fanatic for high-quality data collection and using it to its full potential. And that's why today's conversation is so important and so exciting. Over the next year, you'll hear and see more improvements and information and meetings and forums and questions coming out of NHTSA and its partners across the government related to EMS data. And we hope to start a conversation that is mirrored really throughout the community, from fire stations to state EMS offices, from hospitals to city halls and city councils. And today you're going to hear specifically about two initiatives that we support. But think of them as two important pieces of a much larger topic: how we can use data and information to reach our personal and system goals to help our patients and to serve our communities. So today, we're going to try to answer three questions. Why should we standardize data collection? What can that data be used for at a local level, a state level, and a national level? And how can EMS systems use data to improve their performance over time? This is a roundtable discussion that will address how EMS systems can use their data to measure performance, guide quality improvement efforts, and better provide patient care. And our panelists will also address how national and local data sets allow different opportunities for research and other innovations over time. Attendees are encouraged to submit questions during any point of the discussion, and we will get to them at the Q&A portion towards the end of our hour together. Today's panel is comprised of 3 respected experts in the field of EMS improvement. Dr. Alex Garza is the former Assistant Secretary for Health Affairs and Chief Medical Officer at the Department of Homeland Security. He currently serves as a member of the EMS Compass Steering Committee and chair of the project's Evidence Review Group. Dr. Garza is a professor of epidemiology at St. Louis University. He is the medical director for First Watch and is a former paramedic and local and state EMS administrator. Dr. Clay Mann is the principal investigator for the National EMS Information Systems Technical Assistance Center. Dr. Mann is also a professor at the University of Utah School of Medicine and has conducted research on topics ranging from EMS systems of care to paramedic education. He is truly our resident expert on all things Nemesis. And Nick Nudell serves as the project manager for EMS Compass, an initiative to improve EMS systems through performance measurement. Nick has worked in many roles in local and state EMS agencies. He has a master's in computer information systems and information security. Nick remains an active paramedic who provides medical services at ultramarathons and other endurance events across the country, and I understand participates in many of those as well. I'm Noah Smith, again from the NHTSA Office of EMS, and I will serve as your moderator. Next slide, please. So, why did EMS make such an effort to standardize data collection? The simple reason is to use these common data points to learn more about what we are doing and in turn improve many aspects of our EMS system. You can see as the slide progresses that we've listed a few examples, right, of what we think are excellent uses of standardized data at a local level, a state level, and a national level. But in the end, at its core, right, data helps us do our jobs better, helps us do better for our patients. It helps us prove our value to a variety of people, and frankly, it helps us get paid appropriately for the work that we're putting into it. On the next slide, you'll see that performance measurement and standard data is really part of the maturation of our profession of emergency medical services and how we are better aligning with the rest of the healthcare community. This is really the vision for how we improve EMS systems of the future. You can see standardized data generally through the National EMS Information System. In the middle there, we're talking about starting with some level of baseline performance so that you know what's important to you and how you're doing. Some type of intervention, investment, or improvement, and with standard measures of success that the entire profession can use to benchmark against themselves, to learn from themselves how they're doing over time, we can create a new and improved baseline performance, and the process is continuous. At the same time, here at NHTSA, we are committed to working with our federal partners and agencies and partners across the country to do 3 other things. To continue to invest in research and the development of evidence-based guidelines so that the improvements that we are investing in, we're confident that they actually work. We're committed to continuing a push with our friends at the Department of Health and Human Services on data interoperability so that the data that we're collecting is not just important to us, but it's important to our healthcare partners at every level along the way. And we're committed to updating the National EMS Information System as appropriate. We're going to talk a little bit later about how our data needs to evolve to meet the needs of the users at all levels in the future. But what it really means, what the vision really comes down to, is beginning to shift our culture in emergency medical services towards one of data-driven performance improvement, and I think that's really exciting. On the next slide, we see that we know that we need to show that we're making a difference, and we need to be willing to look at how we can get better and where we are not necessarily performing up to the expectations of our communities. It's important that we're able to prove our value to the community, not just to our patients who rely on us in a very real way, but also to our communities who we serve, to our tax base, to payers, public and private, to regulators, and to elected officials and others. And in an environment of shrinking municipal and state budgets, we're seeing more risk being placed onto EMS agencies and revolutionary change in delivery systems across healthcare. We actually have the data to prove our organizations make a difference and to continuously improve to provide the best care possible. That's the vision we're talking about today, and I think it's really well within our grasp. So now I'm going to hand it over to our panel to provide a very brief overview of some of the projects we're talking about. We're not going to spend a lot of time today on the basics of these programs. If you have questions, please feel free to go to nemesis.org or emscompass.org for more information on the two things we'll be talking about today. I encourage you to do that after the webinar. Let's start with Dr. Clay Mann, who's the Principal Investigator for the National EMS Information Systems Technical Assistance Center, which is funded by NHTSA. Clay, good afternoon, or I suppose good morning where you are in Utah. A lot of people think about Nemesis as just a national database of calls, but the name is the National EMS Information System. It was designed to facilitate consistent data collection, transmission, utilization, and reporting across all levels. Can you provide us a really brief overview of that system?
Yeah, thanks, Noah. That's a great lead-in. Next slide. So Noah's comments are really appropriate. This idea of needing a national EMS information system is incredibly valuable. So here's maybe a bit of a recap of the important uses of data and a supplement that was provided in JAMS, I think, of January 2014 that talked about perhaps the future of use of data in regards to EMS service. And it's clear that data will drive care, but clearly if you look down the list of the values of data, clearly an individual agency, for example, could use data to look at what additional training might be required for all of their providers. They might even try to do some research. They could call their hospitals to get individual outcomes for their specific agency. But that is such a myopic view, right? I mean, if you're not able to compare your data to like agencies or aggregate the data among many agencies at some level to provide the type of information that legislators or others need to help provide the necessary resources, if we just did not try to systemize data across agencies, across states, across the nation, then we would be stuck in this situation with lots of individual data but no way to compare it. And hence the incredible value of Nemesis. So next slide. So Nemesis is clearly built in a way that allows people to compare their data, to benchmark their data. NHTSA basically provided just a giant palette of all data that could be of interest to EMS agencies, and then local agencies were allowed to choose the elements they're interested in, making sure to include the elements that are mandated by the state or collected at the national level. But clearly what that does is at all levels it allows data to be shared or compared, because a local agency, if they're identifying the same elements to collect, that could be compared. All the definitions, all the code sets, all of it is exactly the same, so data can be compared at all levels. And next slide. The true value of Nemesis is not only the standardization of the data definitions and the code sets that are used to describe that data, it's that it was also a transmission standard. It's a way for data to be aggregated. So patient care reports can be aggregated together and, for example, can be sent to a state database and then onto a national database. So just as important is the idea that data can be transmitted seamlessly using the Nemesis standard as it is that we have a standard data dictionary. Next slide. So the outcome of this incredible work is that we now have 46 states and territories all collecting Nemesis-compliant data using the standard, and then a standard data dictionary, and then using the transmission standard to send that data to their individual states and then to a national level. So the next slide we can see here, if you just take a look at a snapshot of a tool that's available to the public on the Nemesis website, you can see that for the calendar year 2014, we have collected 1.8 million EMS events from those 46 states and territories for the calendar year of 2014. What an incredible accomplishment. So not only is the data standardized in their collection, but we have provided a process whereby the data can be aggregated at the state and even at the national level. And this really is an incredible accomplishment. It's really hard to underestimate this. I mean, for example, hospital records across this country, there's no national standard for those to be aggregated. And even if you look at other data sets that are put together for the similar purposes of the Nemesis database, here's a great example. I've included just a snapshot of the HCUP website describing the national inpatient sample. It really is the largest all-payer inpatient healthcare database in the United States, but it literally includes 8 million hospital stays each year are aggregated into this data set, and then it's weighted to represent the 40 million hospitalizations that occur. So it's a sample, it's a weighted sample that really limits its ability to answer questions where we have put into place a system whereby we have a population-based registry that is incredibly useful for answering all types of questions. I'll also just mention here quickly the tool that was used to actually aggregate this data that you was looking at. If we could go back just one slide just quickly. This is the Nemesis Enhanced Cube that is available on the Nemesis website. I'll show you in just a few moments how to access this. But we maintain a rolling 3-year data set of the data and make it available to the public. So there's 53.6 million EMS events in this data set that are available for analysis. So is this in some way valuable to local EMS agencies? Well, I would say it has great value because you can go into the system, for example, look at a similar type EMS agency to yours in regards to urbanicity. Are you paid? Are you volunteer? Are you hospital-based? All those variables exist in here, and then you could look at response times or use of aspirin or use of oxygen, anything that you wanted to, and take a look and see how you compare to the nation. So it's incredibly valuable, I think, even at the local level. Next slide. So there are lots of reports that are made available through Nemesis to look at data quality or to look at surveillance, or even for the state of Utah, you see here for a time frame number of mass casualties. And so it can be used at the national level for incredible value, or even at the local level. For example, as I just mentioned, here's a small snapshot of a dashboard that's available on the Nemesis website looking at pain medication administration for different age groups of kids. So it provides a way for you to take a look and see what's happening across the nation compared to what's happening in your local agency. So these reports are just the beginning of what will be available in Nemesis, and particularly if we move to version 3, the type of information that will be incredibly valuable. So as I mentioned, I wanted to let you know how to access, for example, the Nemesis Enhanced Cube that I was showing just a couple of slides ago. So I just wanted to point to the website, nemesis.org, and if you go to Reporting Tools, Reports, and the National Reports, and create a report using the cube, that would bring you to the reports that you can actually dig deep into the data. There's over 150 elements that you're actually able to stratify the data by. And then if you go to Access Reports, you're able to look at some of the canned dashboards that also can be incredibly valuable. Noah, that's just a quick run-through of the Nemesis project and data set.
Fantastic. Thank you so much, Clay. And just as you were saying, Nemesis really is the totality of this type of data from the very local level to the people who actually type it into the tablets and computers at 2 o'clock in the morning after dropping off a patient at the hospital, to the standard by which that data is aggregated and moves throughout the healthcare system, whether that's aggregated at a local level for their own use, at a state level for surveillance or system planning, or at a national level to try to answer some descriptive questions about what is happening in our nation's EMS systems. This is incredibly important stuff, and it all starts with the EMT and the paramedic at the beginning. So, Clay, you were talking a lot about the system as it exists today, which is very important, but you mentioned something that I know people have a lot of questions about. Let's talk about tomorrow. Let's talk about the process that we're in right now, transitioning from the version 2 of Nemesis to version 3 of Nemesis. Can you just provide us a little information about why moving to version 3, whatever that is so important?
You bet. Cara, could you move to, I think it's slide 17. So yeah, Nemesis version 3 will be incredibly important to the industry, mostly because we've learned a lot of important lessons through a decade of use with version 2. There's been lots of talk about the data quality associated with version 2, and actually, if you take a close look at the data is actually very clean, but is limited by many of the limitations that are associated with version 2. So version 3 will greatly improve our data quality just by improving the data structure, the values and code sets that are available under elements. And then also we've added kind of a national standardization of some business intelligence. And so every vendor product that goes through compliance here at the Nemesis Technical Assistance Center will use the same, for example, business intelligence or business logic to identify, hey, you've identified that this patient is a pregnant male, for example, and all of that data quality checks are kind of up front so that the actual provider completing the record can make those corrections. That will really improve our data quality. We've included a number of additional elements that allow us to look more directly at provider performance assessment, kind of in general, protocol adherence, how often protocols are used and are they adhered to. Probably most important, though, Noah, has been this idea that under version 3, data transfer is now automated. Where under version 2, agencies were providing data to states on a more kind of a calendared approach. States were sending data to the national registry only quarterly, and so every 3 months. Where under version 3, data transfer is now automated, and so data can be sent as soon as it's completed between those 3 locations. And where, for example, under version 2, we were receiving data on a quarterly basis, we were just taking a look at the data we have under version 3, and the average time from the opening of a patient care report to where we actually receive that record here at the national level, I think that average is like 8 hours. And so it's made an incredible difference if you want to look at surveillance or other types of issues. And then just finally, version 3 is structured so that we can now share the data with the rest of healthcare. It is now in a structure where if there's some type of a health information exchange that wants to happen between the ambulance and the receiving ED, or even into a formal health information exchange that a state may maintain, the structure of the data now allows that to happen. Those are basically, I think, the real highlights, Noah, as to why version 3 was so important.
That's great, Clay. Thank you so much. And we're also showing on the screen here a timeline for states to transition from version 2 to version 3 over the next few years, and that's really dependent on buy-in from the local EMS community to understand the importance of the data that they're inputting into the system every single day. Speaking of which, what this means, right, is that we're living in very exciting times in EMS. It might not seem like it, but I promise you we are. Collecting high-quality data for every patient every day is the norm. And that was not an easy effort, and quite frankly, it's not something that all of healthcare can brag about like we can. We're at a point now where we can talk in very real terms about why data collection is so important and what we can do with it to have real impacts on patient care every day. And I'm going to invite Dr. Alex Garza to talk a little bit about how collecting data helps make improvements in EMS, and specifically, Dr. Garza, and the agencies that you've served with and worked with over many years. So, Dr. Garza.
Thanks, Noah, and thanks for inviting me to be on this talk, and welcome to all of my EMS friends throughout the country. It's exciting for me to talk about quality of care in EMS and something that I'm very passionate about. And so what I'm going to try to do is provide a little bit of context on you. So you've heard sort of the what for the data, how the data is collected and things like this. And what I want to talk about now is the why. And so the why is really to improve the quality of care for the patient or to improve patient outcomes. EMS, by and large, has really come of age in the last 10 years with the amount of care that we can deliver, the sophistication of care, but with that comes a tremendous amount of data that we're now only beginning to exploit for delivering quality of care. And with the trajectory of care being now tied to performance, it's even more important now that people are able to understand how to use that data in order to get information in order to improve quality of care. So I'm going to use a couple of examples, and these are examples that are well known to everybody in the EMS community, but I just want to point a couple of things out. So the first one is a clinical condition that most people in EMS know very well, and it's cardiac arrest. And the reason why I chose that one is that's one of the clinical conditions where we have a lot of literature and a lot of data that shows that EMS can improve survivability. Now, it wasn't always that way. Back when I was a paramedic, our survival rates were dismal, and most people that have been in this industry long enough understand that our survival rate for cardiac arrest was hovering around 5% nationally. A number of years ago, though, there were researchers throughout the country that decided to take a look at this data and see how we can improve. So this is just a snapshot of a journal article from JAMA showing regional variation in out-of-hospital cardiac arrest. And as you can look across the cities in those columns, you can see who performs better and who doesn't as far as outcomes or survival to discharge is concerned. And what you will find with each of those EMS services is that it was really a dedication to looking at data in a very critical manner and looking for those nuggets of information in order to improve patient care. So as most people, I think, would say, Seattle is one of the meccas for cardiac arrest survival, but it's not that way anymore because people learn from those implementations that took place in cities like Seattle from them looking at their data. And so this is a very powerful message for EMS providers that we can use this data, translate it into information, and use that to improve patient care. The column that I also want to highlight go back to the previous one, in this slide is the vital status of data missing, the very bottom line there. And you can track that number across the bottom and look at the numbers and compare that to the number of discharged alive. And what you find believe me, I didn't do a correlation on this or anything, but I found this interesting, that the programs that had the better survival rates also had the lowest data missing pieces. And that's an important point to take away. If we want to improve patient care, we also have to be concerned about the quality of data that goes into the patient care report. And it's very important for EMS providers now to realize that what you provide on that either electronic patient care record or on the written record is going to be very important down the road for medical directors, for quality improvement directors, for researchers, and I believe ultimately in reimbursement as well. The next I want to transition now to where I think this is going to lead us. Now, these are a couple of snapshots from the National Quality Forum, and this ties in well to what we're doing with the Compass Initiative. These are metrics that are used in other forms, in other areas of medicine, particularly like emergency medicine and things like that I think are directly applicable to EMS. And other agencies use these as well for reimbursement strategies, and so you have to meet these metrics if you want to get reimbursed for the care that you deliver to these patients. And these are developed over a period of time, and these are are vetted very well, the evidence is reviewed, and experts in the field believe that these are important metrics. And I chose 3 that really cover a clinical condition that EMS knows well. So this is for acute myocardial infarction, and this is the metric for median time to ECG. So I know as an emergency physician, one of my metrics was how fast did I get an ECG on patients that presented to the emergency department with a complaint of chest pain. Next slide, please. So the next one you'll see is applicable to AMI as well, and it's aspirin upon arrival for AMI. So again, I was judged as an ER doc how quickly we were able to deliver aspirin because it's been a proven therapy for survival of acute myocardial infarction in these patients. Next slide, please. And then the last one that I want to show you is also applicable. So it was primary PCI received within 90 minutes. So this is the so-called door-to-balloon time. So how quickly could we get that EKG, recognize that it was a heart attack, get therapy started, and get them to definitive therapy, meaning getting that artery opened. Now, I deliberately chose all 3 of these because these could be directly applied to EMS as well, because they play a role in this. EMS sees patients that have chest pain, and they require 12-lead EKGs now. When I started, it was typical 3-lead. EMS carries aspirin, and they're able to give aspirin to patients with acute myocardial infarction, and EMS has a direct relationship to how quickly we can get patients to the cath lab and get that vessel opened. Next slide, please. And this was summarized very well in this article out of JAMA, it was this New England Journal, with the time to treatment goals for primary PCI. Most of the conversation before this was really revolved around door-to-balloon time. But really what's important to the patient is from the time that they start having chest pain to the time that that vessel is opened and you're salvaging muscle. And part of that time involves EMS, which is why it's important that we collect data on dispatch, on response times, on transport to PCI centers, and delivering definitive patient care. Next slide, please. So above and beyond making sure that we deliver appropriate patient care to improve the quality of care and improve patient outcomes, I think there's also another side to this, and that's risk reduction and patient protection. And this is a big part of what CMS is driving towards as well, is making sure that we're doing the things we're supposed to be doing appropriately and that we're protecting the patients as well. This was a seminal article that was published more than a decade ago about misplaced endotracheal tubes. And this was back in the day before we had the quantitative CO2 monitors. Before this time, most EMS medical directors did not put as much emphasis on making sure that endotracheal tubes were placed in the correct way. Now, of course, they knew it was important, but again, unless you follow the data and unless you're collecting data, you're not going to realize when something is going wrong as well as when you're doing things right. And so using this data, these physicians down in Florida were able to take a look at their rate of misplaced ET tubes in the esophagus amongst the paramedic population and found that it was unacceptable. As a result of this article, many EMS agencies, including the ones that I directed in Kansas City, began instituting programs to make sure that we saw data, we were collecting valuable data and valid data, and were able to review this on almost a real-time basis to make sure that we were protecting our patients as well as reducing risk to our paramedics and EMTs. So those are just 2 big examples. I'm going to close with this last slide that just outlines briefly the benefits of good data. Improving quality of care, we've already spoken about. It's a rich source for research and innovation, but it has to be valid and reliable data. So the input on the front side really matters to the people that are trying to improve care on the back side. Reducing risk to our patients and protecting them. Data is invaluable for improving operations, improving patient outcomes, and I believe will eventually improve financial outcomes if the repayment schedule keeps going the way that I think it's going to go. So with that, Noah, I'm going to turn it back over to you.
Thank you, Dr. Garza, very much. Those are incredible insights and real-life examples of how data is leading to better patient care, both through academic research, but also through very real hands-on improvements in the field, and that's really where the power of this information comes in. I want to just turn quickly to Nick Nudell from the National Association of State EMS Officials. Nick is the project manager for this thing called EMS Compass. And I'm wondering, Nick, if you can just provide us a little information and talk about how EMS Compass fits into this picture of using data at a local level meaningfully to improve care.
I would be happy to. Thank you for the invitation, and good morning or good afternoon to everybody on the call. The EMS Compass initiative is really a collaboration between different people, different associations, different groups, and individual providers, medical directors, and others that have an interest in EMS and measuring the performance of EMS. And the combined efforts of all of these people, many of you may be participating as well, is to develop some performance measures that will help us to demonstrate our value to the community and to our patients. And we're doing this. If you go to the next slide, you'll see how these performance measures are really broken out into different domains to make sure that we cover each of the different aspects of EMS, not just clinical areas, but also the things like EMS fleet management, the data that we're collecting itself, patient care considerations, as well as EMS workforce. You might think of patient safety or provider safety, things like that. So by having different domains to separate the performance measures into, we're able to make sure that we really are taking a broad look at EMS. Now, as we switch to the next slide, a lot of people have wondered what a performance measure actually is. So we've tried to this down into its very most basic components to make it a little bit easier to understand. So on this next slide here, you'll see how each individual clinical area or topic can be broken out into different measures. And each family can be made up of one or more types of measures. Those types are listed there. There's structural, process, outcome, and balancing measures. Those structural measures being things related to the infrastructure of providing EMS. Process are different steps or different things that you would potentially measure with a timestamp. So an example of that might be response time. When you respond to a call, that's a process, and there's different components of that response time. So it's a process measure. Then there are outcome measures where we look at the outcome of processes. We might also look at patient outcomes. So really anything where we're looking at the end result becomes an outcome measure. Then balancing measures are used to kind of, in a way, counteract process measures so that we don't get too, let's say, too focused on the process itself and overlook some other important aspects, such as in response times, where if we only looked at reducing response time to be as fast as possible, we might drive crazy, take risks, run people off the road, those sorts of things, and that's really not what we're looking for. We're just looking for the best response time. So you balance it with other aspects. That might be ambulance crash rates or complaints from the community or things like that, where you're able to balance out the process. So these measures can work together individually or in a combination, and in a combination they become a family or a family of measures. Each of those measures has a denominator and a numerator, and when you put those two together, you end up with a measure score. So that's just the quick overview of the technical part of what a performance measure looks like. But you can really look at any aspect of EMS by simply putting a measure against it. And you find a lot of value in having good data and good quality data when you start to essentially put the math to it in this sort of way with a performance measure. So it really becomes an easy thing to do when you have good data and you have access to good data. And so having the EMS Compass Initiative work groups and committees and all of the participation that we're receiving from the public, we're able to develop performance measures that will work across the country. They'll work essentially seamlessly with the Nemesis version 3 data set and will allow us to measure our performance and demonstrate our value in ways that we have not been able to do in the past.
Fantastic. Thank you so much, Nick. Just as you were saying, right, this is such an incredible opportunity for us to use our data in its most meaningful way possible, right, which is to point to areas in our own systems, in our own localities, where we can do better, where we can improve, and we can learn how to improve and test things in our own way at a local level to see if there's real improvement that can be shown. And that's really exciting, because it's not just about collecting data anymore because it's fun. It's about collecting data so that we can prove to ourselves, prove to those in our community that we are providing the best care possible. And it all starts with that EMT and that paramedic in the back of an ambulance typing on a tough book saying, this is the care I provided. This is the assessment that I saw and the assessments that I did. And that is incredibly valuable when put together with the kind of standard structure that you folks at NSEMSO are helping the country develop. That's really great. I wanted to open it up a little bit to the panel here. Before I do, though, I might just remind folks on the call in our audience today that you should feel free to be submitting questions for our questions and answer section, which we'll get to in just a few minutes, and we'll start prioritizing those questions as soon as they start coming in. But I wanted to open it up to the panel a little bit and try to talk about the connections between Nemesis, the data that we're collecting, right, and the Compass Project, because I think it's really important. So let's start perhaps with Dr. Mann. Clay, how does the Nemesis program support performance measurement, at a local level, at a state level, and at a national level? And if I may pile on, just as importantly, how will the Compass Project inform the future of Nemesis?
Yeah, great question. Cara, I sent you some supplemental slides. If you could go to slide 51, that might kind of inform the question a little bit. Yeah, so version 3 clearly was interested in improving our ability to look at performance at the local, state, and national level. And so here's just a snapshot of kind of the clinical topics that were mentioned that would be important and be included in Nemesis. But it's clear that not all of the domains that Nick mentioned is kind of currently included in Nemesis. And so it's really kind of a dynamic relationship, I think, where version 3 has really been established and kind of honed over the last couple of years. And so there are clearly domains that are available and rich data within each of those domains that will be helpful to the Compass Project, but clearly they may identify things that are incredibly important for us to collect that really aren't currently in Nemesis. And if the decision is made that they should be collected via the Nemesis process, we do have a revision process. It's a timely and but methodical approach. We don't change the standard willy-nilly, but it clearly has the ability to be dynamic to make sure that as we move forward, if there's new procedures, new medications, new things that we could test or evaluate, the Nemesis standard could do that. And I truly believe that the elements that are included in Nemesis version 3, as well as the work of the EMS Compass Project, they're all focused on the local EMS agency and what can help them improve performance, and then those can be aggregated at the state and national level for important benchmarking. Does that answer your question, Noah?
Yes, absolutely, and maybe I'll ask Nick to comment as well. Nick, you've been working with the Compass Project from the beginning, and you've been meeting with the various work groups. Can you comment a little bit about how the Nemesis elements, right, the standard data structure, right? That's being that folks are inputting data into every day. Can you talk a little bit about how that's informing the measurement development process, the measure design process?
Absolutely, be happy to. The primary starting point for all of the measures that we are working towards developing is really what data is available in the Nemesis version 3 data set. And that data set contains many different possible data points that could be collected. And we know that some agencies across the country are collecting more data than others. And Dr. Garza mentioned earlier some of the differences that he's seen between or in the literature showing that people that collect a lot of data having good successful outcomes with their patients. So we're also looking at that sort of thing with what kind of data is available in Nemesis version 3 and what data elements agencies are actually collecting, and then what can we measure from those data points, and not doing it from the perspective of just measuring everything and anything because we can, but what are those important data points that we should be collecting so that we can have the best outcomes for our patients.
That's great. That's great. So, what we're seeing from the NHTSA perspective is that the two programs are very much tied together, and that the data system and the information that we're putting into the system every day at a local level has to sort of be nimble enough and reactive enough to be able to respond to the needs of the users, the ones who are actually benefiting from all the hard work that we're talking about today, and that's really exciting, right? That shows us that we can be responsive to the needs of our stakeholders, and I think that's really important for these two projects to be working together like that. Some questions are coming in, which is excellent, and I feel like we're at a very good point to start to take some of them, and a few of them are fairly predictable, and they are about reimbursement reform. A hot topic every single day, probably as long as I've been alive. I want to throw this perhaps to Dr. Garza. We have some questions about how this might fit into reimbursement reform, and I guess the question I might ask you, sir, is this really about financial reimbursement, right, or is there something else going on here?
So it's sort of a combination of both of those, Noah. So on one hand, it is about improving quality of care. On the other hand, it is the payment system for delivery of medical care moving away from paying for doing things and moving into paying for performance. And so we've seen that with the Affordable Care Act and with numerous other things that are coming about. And so one of the ways that is, I think, a very clear picture of this is something called ValueBased Purchasing, which is one of the programs that was initiated under the Affordable Care Act. And really what this says is that in order for providers to get reimbursed fully, they have to meet certain metrics. And so as you can see from the slide here, these are some of the bullet points from how this program came about. But if we move to the next slide, and I think this one is a little bit more descriptive about how CMS is now beginning to look at reimbursement schemes. So if we could move to slide number 35, that would be a great cartoon showing how they're now starting to look at these things. And so if you see how the pie is how much you're getting reimbursed and how it's weighted for what you do, part of it is the clinical process, part of it is the outcome, and part of it is the patient experience. And so these are from 2014. I've spoken about this before at other meetings, but you can just look at the first one up there, fibrinolytic therapy received within 30 minutes. Well, EMS is part of that 30 minutes, at least sometimes they are. The outcome is mortality of myocardial infarction, and of course we do outcomes in EMS as well, especially for cardiac arrest. And then the one that we probably don't tap as much into within EMS, but I think is going to be coming down the pike fairly soon, is the patient experience of care. So not only are we doing the right things and having good outcomes, but is the experience that the patient has while we're delivering care a positive one as well. And so I took the liberty of mocking up my own slide, which is the next one here, of what this might look like for EMS providers. And so, for example, you might take ECG within 10 minutes of arrival, scene time of 20 minutes, and these are for AMI, and then transport to a PCI-capable center. Of course, the patient experience of care doesn't change a whole lot. It's does the paramedic communicate, was their pain managed, and was the ambulance clean? And then the mortality measure would be a cardiac arrest survival rate. So that's just a really Dr. Garza's view of the future where this might end up. If those same processes were applied to the EMS community that they're applied now to the rest of medicine. And everything that we have seen, read, heard coming out of HHS leads me to believe that they're moving towards this payment structure for all aspects of medical care and not just for the inpatient side. Back to you, Noah.
That's great, Dr. Garza, really, and I think just to sort of bring it back to how we opened the call today, that everything we've talked about, right, whether it is reimbursement reform, whether it is delivery system reform, whether it's improvements in protocols or treatments or medications, has to be data-driven at some level. And so that we're even having these conversations today means that we're at a point in our data collection where we are sort of mature enough to have those conversations, and that's really exciting. I'll add to Dr. Garza's great comments, right, that the Compass Project's sort of main purpose, right, is to work with the EMS community to bring out our culture, right, to one of data-driven performance improvement, so that we can really have these conversations in a meaningful way. That's really great. I would just, let's see, reviewing some of the excellent questions that we have coming in. One is from New York, and I'll maybe throw this one to Clay and ask a little bit about how hospitals communicate with the pre-hospital system. So we get this question fairly often, right, about data interoperability and bidirectional flow of data, which are complicated phrases, right? But it's really about are we building the system that not only allows for but encourages a flow of data from EMS to the hospital, from hospitals to EMS, and from a variety of other health partners throughout a local community, from public health to mental health to clinics and patient-centered medical homes and others. Clay, I'm wondering if you can talk just briefly about something called Health Level 7 and what it means for the data that we're collecting to be interoperable.
Yeah, no, a great question. Cara, I think among those supplemental slides, if you go to, slide 54, fantastic. Yeah, so clearly what Nemesis has tried to do is work with a standards development organization called Health Level 7, or HL7, to develop a national standard, an ANSI-approved standard that basically just means that these standards can be used by any healthcare entity to exchange or transmit data. HL7 ensures that the format is exactly the same in regards to what data you wish to send. It's kind of like providing a standard of how you should fill out an envelope for a letter to be mailed. The letter being the data, and the envelope structure being what HL7 provides. And so, yeah, we've been able to work with them to develop what's called a CDA, or a clinical document architecture, for the transmission of data from the ambulance to the hospital, and now we're working on a similar structure for hospital outcome data to flow back to the agency, and so local agencies will be able to look at the outcomes of their patients. But you can see from this slide, there's lots of different exchanges of data, even just within the Nemesis process, that was standardized or could be standardized. And so we'll continue to work in this way to ensure that we have the transmission methods standardized, that anybody can pick them up and use them out of the HL7 repositories to ensure that data can be shared.
Fantastic. right? And that's really just skimming the surface of what is a very technically complicated and I'm just starting to understand all the facets of it, right? Issue about data interoperability, but clearly we are building the architecture in the system so that EMS data is healthcare data, right? It is part of the healthcare system's data infrastructure because it is valuable, it is important, and should be considered and treated, equally and on par with the other types of healthcare data that's collected for a patient encounter. That's really important, Clay. Thank you so much for that. And as we wrap up, we're seeing several questions come in about the kind of experience and knowledge and education that it might take at a local level to do what we're talking about here. So it's sort of easy for us to talk on a webinar or elsewhere about the importance of data. It's much more difficult for someone at a local level to have a firm grasp on the issues, understand what's needed for them to move forward, understand the gaps and the challenges in their own system, and have the technical expertise to actually work with the data that we're talking about here. We have talked to several relatively smaller agencies across the country who are advanced certainly in the data that they're collecting through the help of their vendor partners, but might not have the expertise necessarily to know how to translate that into meaningful information and meaningful positive outcomes in their system. So I might open this up to all three of you to talk about what a local service administrator, a local data manager can do to start to harness the power of the data that they're collecting every single day. And maybe we'll start with Nick to talk about how the Compass Project sees opportunities for agencies of all sizes and varieties to get involved and to start harnessing that power.
Yeah, this is probably one of the points I'm most excited about for the benefit of EMS Compass. By developing these performance measures in a standard way with the definitions being the same for everybody, it really enables us to take out the technical requirement, or you don't need to be a technology expert or wizard or a data geek to be able to use the performance measures that will be coming from EMS Compass. So it'll be much easier for vendors to build these measures into their systems and for EMS agencies to use these measures against their data because of the standardization involved with using Nemesis version 3 data elements and performance measures that have a common definition.
Fantastic. Yeah, that is. I agree. It is the really exciting part here, right? That with more standardization, it actually makes it more automatic and easier for us at all levels to utilize the data that we're collecting, so that we're not sort of doing one-offs across the country. That's really important. Dr. Garza or Dr. Mann, other comments about how folks at a local level can start to get engaged and get involved, get their hands dirty with their data today?
You know what, this is Clay. Just a quick comment. I know we just have a couple of moments. If I could just share a take-home message, it would be for each of these local agencies to seriously consider the process of moving to version 3, just because it provides all of the tools that will be necessary for the Compass project to work correctly, for the type of standardized and valid and reliable data that Dr. Garza talked about. All of that, I think, will be much improved with just acceptance of version 3.
Yeah, no, and I would just add, really, it's to me, it's more of just a commitment to collecting and analyzing quality data. I can't emphasize enough how important it is to input data reliably and validly from the front end if you want to use that on the back end. And having systems in place in order to collect that data, to routinely analyze it, and then to turn that really into actionable information is the key. So no matter how large or small your service is, that's really what it takes is the commitment from the service to do all of those different parts so that they can better serve their community. And that's really what we're talking about, is doing the best that we can for the patients and to be a value add to the community. But it has to start with that commitment to quality and collecting quality data.
Could not have said it better myself, sir. Thank you very much. And as it is 2 o'clock here on the East Coast, we may unfortunately conclude today's installment of EMS Focus. I really want to thank our panel and our presenters, Dr. Alex Garza, Dr. Clay Mann, and Nick Nudell, so much for lending their time and their expertise to us today. And hopefully, folks were able to get a better sense of the vision that we have for how the various data projects that you might hear about in disparate news articles or on Facebook or wherever you might be hearing about things really fit together, and how it all starts, just as Dr. Garza said, with that commitment at the local level. Today's webinar has been recorded and will soon be archived on ems.gov for future viewing and listening. We've also received maybe a dozen more questions that we weren't able to get to today, and we apologize for that. But we are committed to collecting those questions and posting an FAQ on our website, again, ems.gov. For more information about the next webinar, which will take place hopefully in September, and to subscribe to the EMS Focus webinar series so you get a notification every time we have one of these events, please visit us at ems.gov. Thank you so much, everyone, for your participation, and have a great day.